Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a totally unedited surgery of a cataract with grade 4 nuclear sclerosis. Challenges in this case are hard cataract, the patient is under topical anesthesia, and the patient is not able to look at the light. Patient is not able to cooperate at all. After struggling for some time, after several instructions, I could make the main incision at 135 degree, and now I could inject visco, that is 2% hydroxypropyl methyl cellulose through this incision. I could fill off the anterior chamber with this visco, and now I found that it will be extremely difficult to manage this case without some kind of anesthesia, and I asked for Sub-Tenon block in this case. So a 2 cc syringe is taken and lignocaine 2% is taken in that syringe, and I take a curved needle which conforms to the contour of the curvature of the sclera, and now I take a Vanna scissor, go to the inferonasal quadrant. This is the left eye of the patient. Go to the inferonasal quadrant, ask the patient to look up, hold conjunctiva and tenons in the inferonasal quadrant at a point which is about 10 millimeters away from the limbus. Make a small cut here. This is conjunctiva and this is tenons. You must make an opening in the tenons, and here it is. An opening in the tenons is made, and now I take the needle with the attached to the syringe, a carved cannula, but I could not pass it too much posteriorly, so I injected some amount of lignocaine in the anterior part, and there is some amount of chemos of the conjunctiva, and I injected only about 1 ml of lignocaine. And now after some time, after a few seconds, the patient could cooperate, and now is the time to make the side ports. This is the side port on the right side of the main incision, about 2 clock hours away, and then I asked the patient to look down. The patient could not. So this is a side port on the left side of the main incision, and this is about 3 clock hours away. And now I'm going to make a rhexis. The anticapsule has been incised and the capsular tag has been raised, and now I hold this capsular tag with a utrata forceps. Before that, this is some amount of visco to improve visibility, and now I take utrata, hold the capsular tag, go anticlockwise, guide this capsular tag anticlockwise all around, and do a continuous curvilinear capsulorhexis. Since the cataract is quite hard, about grade 4 nuclear sclerosis, I have made a large rhexis of about 6 millimeter in size, or 5.5 millimeter in size. Now hydrodissection is being done. Fluid is injected, the nucleus is tapped, and the nucleus is rotated. Now visco is injected into the anterior chamber, and now is the time to introduce the tip of the phaco needle. In this case, I am not using OmniGlow because the cataract is quite dense and OmniGlow will not improve the red glow. And now this is removal of some superficial cortical lens matter. And now this is submarine chaff. The tip is buried into the substance of the nucleus, goes through the nucleus towards the opposite equator, and the nucleus is chopped. And the nucleus divides very easily when the tip goes through the substance of the nucleus. Yes, the nucleus has been divided into several fragments, and now each nuclear fragment is emulsified and removed. Phaco power used in this case is 80%. Flow rate is 45 ml per minute, and vacuum is 450 millimeter of mercury. And this is the last but on fragment. Each nuclear fragment is tilted and emulsification of the pieces started from its apex. And at this time we must take care of the surroundings. We must see how the posterior capsule is behaving. Is there trampolining of the posterior capsule? Is there any surge? If it is there, we can use several techniques. We can reduce the vacuum, we can use IOL scaffold, we can employ many techniques to prevent posterior capsular rent. And at this time I am removing the chopper so that the antechamber becomes more stable. But here I came out, I was not sure about the behavior of the posterior capsule. So injected some visco, pushed the posterior capsule far behind, and now I am going to use the phaco needle to remove the last small bit of nucleus. I'm going directly onto the nuclear piece and emulsifying the nuclear piece. Visco is still protecting the posterior capsule. The epinuclear piece is also removed, and the case is almost done. We just have to remove the cortex and implant an intraocular lens. This is visco, 2% HPMC. And now this is a Simcoe cannula. This is a 23G Simcoe, and the cortex from the inferior part is removed, going through the main incision. And now I go through the side ports. I'm going through the left side port and removing the cortex, the subincisional cortex. And now (2% hydroxypropyl methyl cellulose was not used for implantation of intraocular lens. In this case, we are keeping the antechamber formed by irrigation, and a hydrophobic acrylic single piece monofocal intraocular lens has been placed in the capsular bag. The advantage is we don't have to clean visco, and visco-induced raised IOP will not occur in the post-op period. And here we can see a speck of cortex at 12 o'clock. I have missed that, but now since I have seen that, I am going to take the bimanual IA and remove the speck of cortex. Yes, it has come out. And now this is moxifloxacin. And now the side ports are closed by corneal stromal hydration. The corneal stroma becomes thick once it is hydrated by BSS, and the side ports close. Because of Sub-Tenon block, there is some amount of hemorrhage which will absorb in about 2 weeks. We must assure the patient about that after conclusion of surgery. The integrity of the wounds are checked and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, empathy, and great surgical competence.